everybody. Thank you so much for joining us for this session, the importance of multidisciplinary centers. I am Kayvon Freeman, registered nurse, patient services coordinator at ALS Association New York chapter. And also I'm chapter liaison nurse at Mount Sinai Beth Israel in Union Square and Hospital for Special Surgery. Our speakers are today Theresa Imperato, Dr. Stephen Scelsa, and Dr. Anthony Geraci. I'm going to introduce them briefly and then let them start their session. Theresa Imperato is an RN who has been working with the Greater New York chapter, and she's also ALSA clinical specialist and been with us for over 25 years. She has focused her work on development of the chapter's clinical program. She has been involved with initiating and developing the Center for Certification of Excellence at 3 of the chapter centers. And now she's working on the development of more new clinics. Theresa, she's a nurse coordinator at Stony Brook and also chapter liaison at Columbia University Medical College and Northwell ALS Center in Long Island. Thank you, Theresa. Dr. Stephen Scelsa is going to talk about the evidence of better outcome in multidisciplinary center. He is the site medical director of neurology department at Mount Sinai Beth Israel and Mount Sinai downtown. He's director of ALS Center at Mount Sinai in Union Square. Also, Dr. Scelsa is a professor of neurology at the Icahn School of Medicine at Mount Sinai. Welcome and thank you, Dr. Scelsa. Dr. Anthony Geraci is going to talk about the symptom management at the multidisciplinary centers. Dr. Geraci is a director of neuromuscular medicine at Northwell Health and director of the ALS Clinic at Northwell Neuroscience Institute in Nassau County, Long Island. He is an associate professor of neurology at Zucker School of Medicine at Hofstra, Northwell. So the speaker would be first Theresa, then Dr. Scelsa, and Dr. Geraci. And we have Tiffany Carr. She's will be taking your question. You can write your question in the chat box, and at the end of the session, she will bring it up and we answer your question. Again, thank you for your attendance.
Thank you very much, Kayvon. My name is Theresa Imperato. So today I'm going to talk about the importance of the multidisciplinary care model, and I'm going to talk about the different disciplines that you would meet if you came to an ALS certified center or a clinic in development. And I'll explain the difference between the two of them. As Kayvon mentioned, I've been working with the chapter for over 25 years, and for the most part, I've been at clinics for the majority of the time that I've been working with the chapter. So the clinic is newly formed. It will have to have a relationship with the local ALS chapter. The medical director is a neurologist with a concentration in neuromuscular disease. And they have a dedicated multidisciplinary team of providers that work together and are knowledgeable of ALS and have worked with the ALS community. The minimum team consists of an OT, PT, speech therapist, respiratory therapist, registered dietitian, social worker, a registered nurse, and then we have to have an MD, and many teams will have an NP as well. The difference between the clinic and the center have been working longer. They have been evaluated by the national organization. They have research programs ongoing. And then the national organization finally will come and endorse the that particular clinic team, and they will become a certified center. So either way, when you go to one of these programs that is sponsored by the ALSA chapter, it's a one-stop shop. You get there and you get to see the whole team together in one day. My dad died of ALS in 1993. He was 76. My mother was a frail 100-pound or less 74-year-old who was taking him usually 3 or 4 days a week to different appointments. He went to the neurologist sent him to a speech therapist, the speech therapist sent him for a swallow study, then back to the neurologist, then the neurologist decided he needed PT, the PT referred him to OT, and then of course there was a social work visit somewhere in between. So every day my mother had to get up, get him dressed, get him out, push him in an old rickety old wheelchair because we hadn't gotten to the OT to get to the wheelchair situation yet. So when I heard about this program where we put everything together, it was like euphoria for me. So you, in addition to being at the clinic and having a one-stop shop, once you get involved with the clinic, you have access to all the chapter services. In our particular chapter, we have an equipment loan program, we have a transportation program, we have support groups and education programs like we're doing these couple of days. We also have a care management program. And then there's also the overall concierge care plan that we provide through the clinics. So the different members of the care team, I would like to start with the coordinator. Now the coordinator is usually a nurse or a social worker that is involved with the clinic on a day in, day out basis. Some of the other team members may only be involved with the clinic the day that they go there, or maybe one other day if they're involved in some sort of research or something like that. So the coordinator would maintain the schedule. They maintain the doctor's appointments, the patients coming back and forth. Once the clinic is going for that day, they maintain the flow of the clinic. They move people in and out of the rooms, move them along. So if the PT is taking too long with the patient, the clinic coordinator may knock on the door and move them on. They maintain the post-clinic meetings, and they maintain relationships between the patients between clinic appointments, and then of course communicates everything to the entire team and to all the patients. So communication is a key factor in the clinic coordinator's role. The occupational therapist it will assess and recommend interventions and adaptive devices that will increase participation in desired and meaningful activities of daily living. I oftentimes refer to the occupational therapist as the gadget person because they are the ones that come up with the extra little gadgets. Like one of my favorite things is to cut a piece of meat. Instead of using your old-fashioned steak knife to get a pizza cutter and roll it back and forth across the meat. Something that I never would have thought of, but the OT mentioned it one day, and now I make that recommendation a lot of times to patients. The PT assesses the patient's range of motion, strength, and overall physical function, and will make recommendations for adaptations in activity and mobility devices so that the patient can stay functional and safe for as long as possible. So sometimes it's a no-brainer to the PT that the patient can't do a certain thing, but the family and the patient don't realize it. So even transferring from the bed out to, to get up and stand is a big problem, just the mobility in the bed. And the PT will address things like that. The speech therapist has a dual role at most clinics. The speech therapist assesses the patient's swallowing because we want to maintain safe swallowing. Some of our patients don't have the ability to swallow or have a poor swallowing function very early in their disease process. And the speech therapist needs to assess that and make the proper recommendations for the change of diet and change of liquids. And then communication-wise, the speech therapist is also going to be able to improve the patient's communication skills by training them in compensatory strategies to improve speech intelligibility, and or the use of alternative augmentative communication devices, an AAC device. So there are very low-tech devices and much higher tech devices to aid in communication, and the speech therapist will discuss that. And if anybody was on yesterday, there was a session on mobility and communication and technology to help people live better. And these two slides that I just did, the OTPT and the speech, were all encompassed in those in that session yesterday. And you can listen to it if you missed it yesterday. We have it recorded. The care team also has a registered dietitian. And the dietitian will assess oral and fluid intake and works along with the speech language pathologist to provide adequate nutrition, which sometimes needs thickening liquids or a change in diet consistency. When the patient can no longer get enough calories in a day or enough fluids in a day to maintain their strength, a tube feeding will be needed. And that's the dietitian will make that recommendation to the patient along with the doctor, and then the dietitian will prescribe the appropriate formulas and fluid volume needs for the patient so that they get enough calories, proteins, fluids, vitamins, and minerals. We also have a registered respiratory therapist on the team. And that therapist will assess for symptoms of respiratory muscle weakness, and pulmonary function measurements will be taken during the clinic appointment. Based on the testing results and the patient's comments on how they're feeling and how well they're doing, the respiratory therapist, along with the medical team, will make recommendations for equipment such as non-invasive ventilator, NIV, or MIE, also known as an inexsufflator or a cough assist device. These devices will help maintain pulmonary function for the patients. The care team also has a social worker who also has a dual role. The social worker will educate the patients on benefits such as Social Security disability, Medicare and Medicaid, and the Medicaid process. The social worker will help set up trusts and maybe discuss or help evaluate CDPAP programs for the patients to have care in their home, and will help them choose a managed long-term care that will best suit the patient. They will refer the patients to community agencies to assist with the Medicaid application or meal delivery program or elder care attorney programs to help with wills and deeds like that. They will also discuss with the patient and the family advanced directives and assist the patient with the completion of documents such as a healthcare proxy, a MULST, and a POLST, depending on which state you live in. The social worker will also complete a psychosocial assessment and provide the patient and their family with supportive services. They will refer to community programs, community therapists, and also to ALS support groups. The registered nurse helps patients and families to understand all the medical jargon. There's a lot of chitter chatter that goes on in their appointment, and most of the time when I walk into the room at the end of the day, they're like, whew, we got a lot of information. And it's my job as the RN to help them understand everything. And they work with each member of the care team on behalf of the ALS patient and their families. The RN will also assist patients with documentation, with the doctors and the medical team with documentation if we need follow-up. And we also help the doctors when they have appeals for the patients. The RN is oftentimes the clinic coordinator for the team if it's not the social worker, and therefore they will refer patients to the veterans programs if they are VA. If they are a veteran, they'll report to the VA program. They'll make home care referrals and provide a letter of medical necessities and insurance appeals and things like that. So if the team is lucky to have a nurse practitioner, they, in addition to doing routine follow-up care, the nurse practitioner specializes in complex care coordination. So if the patient needs a little bit more, maybe has a couple of comorbidities, they'll help with that. They also help with advanced directives. And when there's an elective procedure, like a feeding tube, the nurse practitioner will put that little extra hand-holding in place and make sure that everything gets safely delivered for the patient. So the MD, the neurologist on the team, is the overall team leader. He or she is the one we go to when we have questions about recommendations or the needs of the patient. They are the diagnostician. They are oftentimes the researcher. They're definitely the team educator, but they're also the patient and family educator. They are the specialist. Without them, we wouldn't be able to run the clinic. They are the glue that keeps the team together, and ultimately, they are the final word on what happens with the patient. If it's an ALSA clinic or a certified center, we are lucky enough to have a chapter liaison, and they are always a member of the chapter staff. It could be a social worker, it could be a nurse, but in some places I know that there are other members of the chapter staff that are actively involved with the clinic as the liaison. So what the liaison does is they connect the patient to the chapter, they connect the patient and the clinic team together, and they also connect the clinic team to the chapter and back and forth. So they are a bridge between all. Included in many teams, but not required, are nurse practitioners, genetic counselors, palliative care practitioners, chaplains, hospice care nurses or social workers, and various therapists. In some clinics, they have a music therapist that will come and spend time with the family, or an art therapist. Some have psychologists or psychiatrists right on the team, and some have pulmonologists on the team as well. So every clinic has their own fingerprint, and they have their own way of running things. As long as they have that bare minimum that's recommended by ALSA, the other stuff is just, icing on the cake. So what happens when you come to the clinic? So if you're a patient or a patient family member, you're going to be seen by the team, usually on a quarterly basis. Sometimes we move those appointments quicker, 6 to 8 weeks. Sometimes we may stretch them out to 4 months or longer based on the progression of the patient or the patient's specific needs. The visit usually takes between 2 and 4 hours. Sometimes, depending on how many members of the team are there, depending on the patient's needs, it could be longer or shorter. When you come to the clinic, the patient is seen by every team member and the MD and the NP, or the NP. The NP will actually step in on the role of MD if the clinic is very busy. Most of the time, the clinics will have 4, 6, maybe 8 patients scheduled to come in at the same time or pretty close to the same time, and the teams rotate in and out of the rooms. So it's a very busy, like Grand Central Station, trains coming and go, and that's the way we have to run the things as a coordinator. The patients are usually seen in a clinic setting. Many of the clinics are set up in the neurology department in their outpatient clinic, and the patient will be placed in a room, and we rotate in and out. Sometimes patients have to go to see the PT or go to have their breathing test done, but in general, it's usually in a standard clinic setting. And in the last year and a half or so, we have added telemedicine visits, which were rarely done prior to March of 2020. But since then, our patients needed to be seen, and we needed to see them. And we were able, in every clinic, we're able to figure out some sort of telemedicine program where the team or most of the team would be able to see the patient at once. And in some places, they're still doing just telemedicine, and some places are doing a hybrid program where maybe 1, 2, 3 patients are being seen via telemedicine while an equal number of patients are being seen in person. At the clinic visit, this is something that many people ask about. Is the physical therapist going to be doing a physical therapy session on me? No, not at all. What's happening with all of our therapists is they are doing an evaluation, and they're making recommendations for your needs outside of clinic. No therapies are done at the time of the visit. The team members will then discuss their recommendations with the doctor or the nurse practitioner, and if agreed, they will make that prescription for whatever recommendations are being made. And then the referrals will either be handed to the patient if they're in person, or mailed to them, that day or the next day for whatever prescriptions or referrals are needed. After all the patients go home, the team stays behind, and we have a post-clinic team meeting. We discuss each and every patient that we saw that day, and all of the team makes their recommendations known to the rest of the team, so no conflicts are noted. For instance, maybe somebody had more mucus, and the respiratory therapist may have said, oh, drink more water. But meanwhile, the speech therapist said, you can't drink water anymore, you need to thicken your liquids. So then it would be the care coordinator, the team coordinator's job to make sure they reach out to the patient and explain to them the ways that we've decided in the meeting how to thin that mucus and get the proper hydration in. We work together to make the best plan of care for the patient. And we know each patient is different. We know each family situation is different. And we try to develop each plan of care perfectly to suit that patient and their family or caregivers. So after the clinic, that's where the concierge program or process begins. The coordinator is then staying in touch with the patient and their care team, their family team, and the process of referrals get done. So if some things need more hands-on for the coordinator, that will be handled back in the office. Other things may be a discussion with the patient, their family, and the caregivers, and then the coordinator will go back to the doctor to discuss what the family and the patient have come up with. And then we try to promote a case management atmosphere. Sometimes the situation with the patient is a little too much for the coordinator to handle since there's so many other patients, and then they'll go to the chapter and ask them for a little of assistance from the regional team members or some chapter staff members. So, is there a clinic for you? Is there one nearby? Do you need to go to one nearby? Can you travel? So here in the tri-state area, the Greater New York chapter encompasses the 5 boroughs of New York, all of Long Island, the lower Hudson Valley, and a large portion of New Jersey. So we have clinics, 3 certified centers in New York City, and we have 1 clinic and organization, which is, getting itself ready to become a certified center at the Bronx VA. That 1 certified center or that 1 clinic and organization in New York City can only be utilized by the veterans, but the other 3 centers certainly can be anybody in the tri-state area. We also have people coming from far distances, other countries and other states to come to our centers in New York. Long Island has 1 certified center at Stony Brook and 1 clinic and organization at Northwell. Of course, you don't need to live on Long Island to go to either one of those, but if you don't want to travel into the city, you certainly can come to one of our Long Island sites. In New Jersey, we have 1 certified center at Rutgers Robert Wood Johnson and a clinic and organization at Hackensack. So 2 different ends of New Jersey. If you don't want to travel into Manhattan, or you've done that and it's been too much for you, then please find yourself a clinic nearby. And then Hudson Valley, we have 2 what I'm calling associate clinics because I don't know what else to call them. But the Hospital for Special Surgery is a certified center in Manhattan, and Columbia University Medical Center is a certified clinic in Manhattan. And both of them have opened up a smaller clinic, usually seen once or twice a month as opposed to weekly. And most of the team are moving from Manhattan to go to those clinics to see the patients in the Hudson Valley area or Connecticut so that they don't have to travel into the city. The Greater New York chapter is affiliated with all those clinics that I just mentioned. And if you want more information about a clinic that's near you, you can call the chapter patient care services department, and you can get the direct phone number or address for those clinics and the clinic coordinators at each one of those places. Their number is 212-619-1400. That's a chapter number. New patients, if they want to be seen at one of the centers, they have to see one of the center's doctors before they go to the full multidisciplinary clinic appointment. So they need to be seen first, just to get the confirmation of the diagnosis and maybe to get a feel of the doctor. And then the appointments are made by the location through the coordinator, not through the chapter staff. Thank you for your time. And here's my information. If anybody would like to reach out to me, I believe now we're going to go, I guess Kayvon is going to introduce the next video. Thank you.
Thank you so much, Theresa. Wonderful. And so the next representative is Dr. Scelsa, which I introduced him already. Thank you.
Welcome, everyone. In this session, we are going to be discussing the role of the multidisciplinary ALS clinic. This is the approach of the ALS Association, and it's been a successful one at providing optimal care. I'm going to start with a little history of our center and how things evolved in New York. Historically in New York, Columbia University at the Neurologic Institute and the main Mount Sinai Hospital had a long history of specialty ALS care in Manhattan. Both sites had multidisciplinary centers that were sponsored by the MDA Association. Then in the mid-90s, Doreen Gordon initiated the New York chapter of the ALS Association, and she was looking for a clinical site. And with the assistance of Matthew Fink, who was chair at Beth Israel at the time, she selected Beth Israel Medical Center as their clinical site in our new outpatient complex in Union Square. And to start, Herb Schaumburg was the director, and I was the co-director for the first year. And Dr. Schaumburg at the time was the chair of neurology at Albert Einstein. And we modeled our center after observing Terry Hyman Patterson's ALSA Center of Excellence at Hahnemann Hospital. We all visited down there and spent the day there, and really modeled our center after the way she had set things up. And this was the ALSA model. One thing ALSA had provided was a lot of support, financial support for staff, which made it possible. These are the multidisciplinary care goals. And so, this provides one-stop shopping, and it's comprehensive care with providers in different fields who all have expertise in ALS care. So this allows providers with different expertise to collaborate. So you get collaborative care in a single visit. And the type of issues we address in the clinic are symptom management. And Dr. Geraci is going to talk more on this, but there are many issues with ALS that need clinical care, such as excess saliva, depression, respiratory problems, nutritional issues, spasticity, muscle cramps. And we try to address all these issues each visit, which are typically every 3 months. One of our goals is to maintain independence and comfort for patients. We help obtain durable medical equipment and train in its use. We provide emotional support, and we monitor disease progression in various ways, such as some scores of manual muscle testing. Some centers use dynamometry, where you have a device that measures force by pressing with your hand. We also look at functional scales like the ALS FRS, which is also used in clinical trials and is clinically useful, as well as monitoring respiratory parameters such as forced vital capacity and maximum inspiratory pressures. We deal with home safety issues, and sometimes, we help in finding more accessible homes, home care assistance, end-of-life issues in palliative care. I'm going to discuss palliative care more at the end of my talk. We have added a palliative care neurologist to our center in the last year, and it's found very helpful. She attends the center one clinic visit a month, and we direct patients who are more in need of that type of care to her. There's more recent availability of disease-modifying drugs. Other goals, clinical trial opportunities. Patients want to try new drugs that are being developed, and we're starting to have some real, though modest, successes with new medications that slow the disease. And we want to empower patients to make informed decisions and individualize the care. There's not just one way to care for patients. All care has to be individualized based on patients' beliefs and wishes, and we really strive to individualize the experience for each patient. So there is a literature about improved outcomes with multidisciplinary care in ALS. So I'm just going to briefly review some of that literature. Choi et al. In 2004 had an article that showed patients attending a multidisciplinary clinic have fewer hospital admissions and shorter durations of stay than those who attend general clinics. Then Brian Traynor, who's a geneticist now at the NIH and trained in Ireland, had written a couple of papers looking at this, first in 2003, that showed that in Ireland, ALS patients followed in a multidisciplinary clinic were younger, 60 versus 65 years, received Liaison more frequently, which was the only disease-modifying drug at that time, 99 versus 61%. Median survival was 7.5 months longer in a multidisciplinary clinic, and it was even longer than that, 9.6 months when patients had bulbar onset. And 1 year mortality was decreased by 30%. They had compared the ALS specialty clinics to just general neurology clinics in Ireland. Survival benefit was identified for patients who attended the multidisciplinary ALS clinic in the Republic of Ireland. And this was very statistically significant. This was a subsequent article in 2014. Then over 10 years ago, a group of experts got together for the journal Neurology, which is the main neurology journal in the United States. And Robert Miller and colleagues reviewed literature to date at that time and found that multidisciplinary clinical referral should be considered for managing patients with ALS to optimize healthcare delivery and prolong survival. They found level B evidence, which means that the scientific evidence at the time was of moderate quality, not the highest, but it was of pretty good quality and likely to be accurate, and that it may be considered to enhance quality of life. For that, the data was more limited, small series of patients or from single center studies, and that's called level C evidence. And this was from another study in Ireland from Dr. Traynor and colleagues, and they compared survival in patients in the Republic of Ireland versus Northern Ireland patients, and they broke up patients from the Republic of Ireland into those in a multidisciplinary specialized clinic versus not being followed in a specialized clinic. And the more gradual slope of decline in the specialized clinics in the Republic of Ireland show a greater survival. And this is compared to patients in the Republic of Ireland who were not in a specialized clinic, and patients in Northern Irish patients fell somewhere in between, and it probably reflects that there was a mix of some multi-specialty care, but their system of multi-specialty clinics was less evolved at the time. Then in terms of patient perceptions, Zach Simmons had conducted a study where there's an online survey about the perceptions. In an ALS clinic. And the unique aspect most cited was integrated care. Other reasons were expertise, access to clinical trials. There were some downsides with the questionnaires. Some patients cited long visit times and further travel. Certainly since the COVID crisis, many of our centers now do telehealth and video visits. Some are still doing that exclusively. And so this does help alleviate some of the hardship with having to travel. And in terms of palliative care, referral were most often triggered by advanced care planning. This was a study by Mass General where they reviewed their experience after incorporating a palliative care physician in their multidisciplinary center. And advanced care planning was the reason for 91%. In the initial visit with palliative care specialists, the topic most frequently covered were goals of care, 84%, anxiety, depression, 35%, and also decisions about feeding tubes and tracheostomy. This is more data from that study. So topics covered during palliative care sessions: advanced planning, goals of care, 84%, anxiety, depression in a third, coping and caregiver support. One of the weaknesses of our healthcare system is we don't provide a lot of support to caregivers. So this is a way to reach out and help caregivers who, have a difficult task of taking care of their loved ones with ALS. Sialorrhea is an issue, and then less commonly dyspnea, pain, or constipation. Coping and caregiver support, and then medical decision making about feeding tubes, tracheostomy, and hospice care. Triggers for palliative care specialist consultation. Patient-specific triggers were psychosocial complexity, premorbid depression, anxiety, early interest in advanced care planning, presence of young children, or overburdened caregiver. Disease-specific triggers were cognitive or behavioral changes, high symptom burden, rapid decline of functional status in terms of strength, and transition points in care, so needs for feeding tube, ventilatory support, more frequent hospitalizations, or hospice. So I'm going to stop there, and I hope you found this helpful in supporting the important role of multidisciplinary care in ALS. Thank you.
Thank you, Dr. Scelsa. That was wonderful. And as I mentioned before, Dr. Scelsa is the director of ALS Center in Mount Sinai, Beth Israel, located at Union Square. I'm very proud to be affiliated with that clinic, which is the oldest clinic actually, and as a liaison from the chapter. Now, Dr. Anthony Geraci will continue with this morning session. Thank you.
Thank you. So let me bring up my slides. All right. So today I will be speaking about ALS Multidisciplinary Clinic symptom management. And this last 15 or 20 minutes will be really dovetails very nicely with the two prior presentations. I need to, there we go. So the ALS MDC, I'm going to refer to it that way, just it's a little bit less of a mouthful. We're talking about patient-centric symptom management. And what do I mean by that? As you probably have seen from the last two presentations, inherent in multidiscipline care is the word multi, right? There's a lot of people that can be associated with the patient with ALS, both in their constellation of where they live and or work, and on the other side in terms of care and the multiple disciplines that come together at ALS clinics and centers. So to optimize care, I like to divide, when I talk about symptom management, there are straightforward symptoms, which we can call physiological symptoms, that are a result of the disease process and progression, such as weakness, clearly the most obvious and actually the definition of ALS, muscle cramps, sialorrhea or excessive saliva, which, secretion clearance, trouble with mucus and swallowing, or excess saliva and drooling. There's just those two right there could take several practitioners coming together and talking about how we're going to best treat this patient. Pseudobulbar affect or emotional lability, inappropriate episodes of emotions, laughter, crying, and so forth, trouble sleeping, shortness of breath, GI problems, spasticity. Head drop is a physiologic symptom, and that has to be addressed. Depression and anxiety has been mentioned, slurred speech, dysphagia, laryngospasm, hoarse voice, and then finally pain would go under the rubric of physiological symptoms. And then we have symptoms that have layers of complexity that are, I call them the functional symptoms, and others do as well. And they fall under this rubric of layering. For instance, a functional symptom in the realm of mobility may be that the patient keeps tripping on the foot due to foot drop, and that leads to falls. That's a little bit more complicated, you can see, from drooling as just a straightforward, okay, what medication might we use for a patient who has excessive saliva? Moving in bed, that has layers to it. It depends on how weak the patient is, how severe the problem with moving in bed is, and whether or not they live with somebody and have help 24 hours because they live with a family member, or if they're living alone and they may not have help at night, and then that brings in layers of complexity. So you can see that all of these symptoms listed here, bathroom safety, hygiene, accessibility around the home, that's going to be defined by where the home is. Is it an apartment? Is it a house? Is it a two-floor home? And all of this leading to loss of independence, which from the patient's perspective is a symptom, right? Hygiene, I mentioned, toileting, dressing, eating meals. Theresa talked about occupational therapy and helping the patient with utensils, preventing aspiration while eating, addressing the patient's loss of eating pleasure if they have to have a peg placement. All of this could lead again to this sense of loss of independence, which very frequently leads to depression and anxiety. So these are complicated, more what we call functional symptoms, communication impacted, and ventilatory hypoventilation, the anxiety that comes with that, aspiration risk, and so forth. So the symptoms are very, very broad, and so we approach it in this patient-centric care model. And what do I mean by that? The patient is associated with usually family or friends, coworkers, perhaps, and anybody in their personal life. Maybe it's a young patient with young children. It may be a much older patient with adult children, or an older patient who have siblings, or just a friend. We see that not infrequently, where there's an older patient who lives alone and has no immediate family with them. But they will generally have at least one friend or a coworker or somebody close in their life. And then on the other side are all the providers that are caring for the patient, family that I mentioned, agents, employers, lawyers. The patient is in the middle of this evolving and revolving universe, right? That's circling around the patient. And so the challenge is identifying the layers and the points that are circulating around any one patient, because every patient is so unique and individual. So we look at, in terms of symptom management, how does each physiologic or medical symptom affect the patient? And we need to consider that because that's going to, fall into the mix when we decide if there is a medication to address a physiological symptom, and if we should use that medicine. Not all symptoms need to be treated if they're mild. And there's the multidisciplinary clinic is just a really good platform to discuss these issues with the patient and with all of the care providers and specialists that are there helping to treat the patient. And the same thing goes for functional symptom complexes. And this is, as you can see, hopefully from the prior slides, the more complicated question of how do they affect the patient's circle of support? How do these, how does the tripping affect the patient? How does the fact that the patient needs a power wheelchair affect not only the patient, right? That's fairly straightforward if a patient can't ambulate anymore and has access to a power wheelchair. That's not a difficult question to answer. But where does the patient live? The patient lives in a fifth floor walk-up. How do you get the patient? How do you get the chair to the patient? And what does the patient do with the chair once they have it? Are they only going to use it in the home and they're not leaving the home at all? That may be the case, but therein lies an example of the complexity of some of these decisions. And these functional symptoms, as I've mentioned, are very important to address. And the multidisciplinary clinic is just essential for this, because we're addressing patients' sense of loss of independence and depression that can come from that, and anxiety. We're addressing the family's needs. Dr. Scelsa mentioned this, burden of care. We are not well set up for that in this country, and we don't tend to address that on one-on-one visits, a doctor to patient. And so through the clinic, we have a platform where we can address that. And if the patient is still working, and some in the early stages certainly are, how does the employer, or is it even a question that has to be approached for the employer in terms of accommodation at the patient's workplace? So when we look at symptom management, we can again break them out into medication management or multimodal treatment. Medication management is really an example of one symptom, one pill. Essentially, if you have excess salivation, there are medications such as glycopyrrolate that work very well. Botox injection into the parotid glands works very well. So one symptom, one pill. Do we use that medication? Some of these symptoms may not be unique to ALS. For instance, pain. A patient, I can think of several patients who have ALS, and they also have a lumbosacral radiculopathy, a sciatic type leg pain that predates their diagnosis of ALS. Maybe it's worse with ALS and they're not moving as much. That pain can be quite severe. So some of these symptoms are not directly related to the condition of ALS, but they have a medication often that will be effective cramps. Mexilatine has been shown recently to work very well. So we have a range of options, but we also have to consider the risk of polypharmacy and having a patient on too many medicines, and then having side effects that you're chasing your tail and you're treating side effects. Sometimes the best treatment is looking at all the medications that the patient has. For instance, some patients will complain of very, very dry mouths. Now, sometimes that's because of the way that they're breathing and drying up their mucosal lining as they mouth breathe. And it may be that they're on too many medications that dry up their mouth. So we have to always consider polypharmacy. Multimodal treatments are really suited for, or I should say the MDC model of clinic is really well suited for the multimodal treatments, because these are the functional symptoms that are layered and complicated. They may be concerns of the patient or the caregiver or both, and they require multiple disciplines and specialties, as outlined so nicely by Theresa at the beginning of this session. So, as I mentioned, medication management could include glycopyrrolate, tricyclic antidepressants for sialorrhea, botulinum toxin. Anxiety is very common in ALS, and benzodiazepines are absolutely the most effective agents for generalized anxiety. And this population of patients facing a a terminal illness that we only have the ability to slow down progression, precipitates anxiety in almost everybody. And the question is, how bad is the anxiety? It can get so bad that they're losing weight and not eating, not because of dysphagia, not because of trouble swallowing, but because they're not sleeping and they're not eating from anxiety. So under normal circumstances outside of terminal illness, we tend not to use benzodiazepines for anxiety because of addictive potential. We don't really worry about that too much, if at all, in patients with ALS, because we have such a powerful tool. Forgot to put my light on. Because we have such a powerful tool, we should take advantage of these. That's also, I would note that with pain, as you see here, when narcotics are judged to be needed, we know how to treat pain well with narcotics, and we should use those in the appropriate context. Cramps, I mentioned, mexilatine, constipation and diarrhea, maybe just a nutritional assessment and changing the feeding that they're getting. Multimodal treatments are more complicated and require multiple disciplines usually, and so the MDC model that you're seeing is really well suited for this. And I've just got examples here. This is not in stone. And every patient is going to be different, and different disciplines will be more important. So I just have as an example, for instance, AFO, ankle foot orthosis, orthotics for foot drop would be recommended perhaps by OT and PT. The need for a cane walker and wheelchair, same thing. Maybe a hospital bed with rails and a mattress overlay is needed for the patient, and PT has made that assessment and then works with the ALSA nurse in terms of procuring the durable medical equipment. And so these are the complicated issues that come up: impaired ADLs, using Velcro replacement in place of shoelaces, thinking out of the box, utensil, foam collars for eating. I love the pizza slicer example for steak that Theresa mentioned. So coming up with different ways that patients can adapt to the progressive nature of their weakness. Some have referred to this as reverse or step down physical therapy, right? We are the therapists and the team that comes together, social worker helping out with skill, getting home care in the home, dysphagia, nutrition, all of the disciplines, that's speech language pathology, everybody coming together and coming up with ways to help the patient as they step down to the next level of functional impairment. So these multi-layered, multimodal treatment approaches, communication, assistive and augmentative communication devices. I have patients that use the erasable boards, the chalkboards with erasers. And they've been given the computer AAC devices. They don't like them. They use the chalkboards. And so we'll use the speech language pathologist, maybe the ALSA nurse would be involved there. But probably social work will be helpful. Hypoventilation and respiratory issues. Does the patient need BiPAP? Do they need a tracheostomy and ventilator support? And notice how I keep saying, do they need it? We then circle back to what does the patient want? So, and that's goals of care, and always having this recognition that you see at the bottom that invasive care choices may change over time, and they really need to be patient-centric, as I started this talk. From the very first moment that I have or broach the conversation with the patient and or the family of end-of-life care issues or hypoventilation issues where ventilatory support starts to come into play, or eating and swallowing and nutrition, I'm very careful to know and to elicit from the patient what their wishes are, recognizing that they may change over time, and then honoring those wishes with the patient, because it's their body, it's their destiny, it's their disease, and everybody is different. So as long as we keep that in mind, we will never go astray when we are approaching patients with ALS. They are at the center of their social and treatment universe, and they are the most important person in that patient-centric model in a multidiscipline clinic. So this very broad range of ALS phenotypes and presentations results in just a myriad of symptoms, and every patient is wonderfully unique as an individual person, and they're also unique in their needs in terms of symptoms from due to ALS and functional impairment. And so the MDC ALS Center and Clinic model is very effective, and as I hope you can see, you've very well suited and has been shown to be an effective approach in managing patients with ALS, managing their symptoms and the complexity of their symptoms from this progressive illness. So thank you very much.
Thank you very much, Dr. Geraci. Wonderful information. As I mentioned before, Dr. Geraci is the director of ALS at Northwell, and that is located in Nassau County, Long Island. Tiffany, do we have any question that we can ask our expert?
Yes, I have a question here. We have about 15 minutes, so if folks would like to go ahead and type in their question in the Q&A, you can go ahead and do that. You can either use your name or type in anonymously. So we have a question about a pulmonologist. Apparently, there's some discussion about whether the AL progression, because it's a respiratory compromise, would it be appropriate to have a pulmonologist in addition to the neurologist in the multidisciplinary care team model? So could anyone offer their thoughts on this?
Yeah, I'd be happy to answer that. That is very true. Most ALS MDC clinics and centers either have a pulmonologist either on site or very nearby. If it's an academic institution where the pulmonologist is in the same building, maybe a floor down, they're very close and very accessible. In our here in Nassau County at Northwell, we work with a pulmonologist very closely who is familiar with the needs of an ALS patient. The pulmonary needs of an ALS patient stem from what's called a restrictive neuromuscular pulmonary or respiratory decline and failure. So it's a very particular kind of niche in pulmonology, and it is therefore important that the pulmonologist associated with the clinic and seeing clinic patients is well versed in the needs of these patients. It's not mandatory or even necessary to have the pulmonologist on site at clinic day, because the respiratory therapist, along with the ALS neurologist, most, if not all, ALS neurologists at these clinics and centers have been doing this long enough and are versed in the essentials of pulmonary function, sufficient to work with the respiratory therapist to make decisions on timing of pulmonary care. There are times where I can think of one in the past year, really, where a patient needed to go urgently to see the pulmonologist, and we gave him a call, and that day the pulmonologist was seeing the patient. But those are very, very infrequent instances. So we do work with pulmonologists. That was a great question.
I'll just add that, when I mentioned the one-stop shop, it is hard to get a pulmonologist or any other specialist to attend the clinic. So like Dr. Scelsa mentioned, he has a palliative care doctor that comes once a month. Having a pulmonologist spend their day or their hours in the day with us at the team might be a little too much to ask. And the respiratory therapist can do the assessment that would be done in the pulmonologist's office. And then we can, like Dr. Geraci just said, make that referral, that urgent referral if necessary. But oftentimes the devices can be ordered based on the respiratory therapist's testing and the neurologist's expertise.
Okay, great. We have another question. Actually, Theresa, this is for you. You mentioned a MOLST, MOLST. What is that?
That is the end-of-life planning device that is now used in addition to or greater than a healthcare proxy, and it's usually filled out with the assistance of your primary care physician or your neurologist, and many nurse practitioners will do it, and social workers will also help. And it's updated every time you go to the doctor. It's opening the eyes to the patient and the family of upcoming needs that you may have. And it's part of the end-of-life decision packet that would help patients make decisions openly with their family.
Great, thank you. I have another question here. When is it appropriate to introduce palliative care?
I'll take that one. So that is a very good question, and thank you to whoever asked that. I was going to bring that up in symptom management. It's very unique, clearly, depending on the patient. If a patient, an example that is readily seen is a patient who, from the very beginning of diagnosis and through until they are in respiratory compromise, a patient who clearly defines, I do not want to be on a ventilator. I do not even want non-invasive ventilation. We have patients who make that decision, and palliative care in that patient is going to come earlier than the patient who says, no, I want to be on non-invasive, and then when I need the trach, I want the trach. I want to be around for my children or whatever reason that they have. Many patients make that decision because it's scary. It's scary to contemplate not being able to breathe and passing from that, and so patients that it's all of us. I challenge everybody who's watching and participating today to ask that question of yourself, and you'll see immediately that you may or may not have an opinion on it, on what you would want, but it's when I think about that question for myself on a monthly basis, it changes, and over the years I've realized, wow, this is something that can be very much in flux, and I've over the years I've thought differently just for myself when I pose that question, which I know is a hypothetical. There are patients who there's a combination of difficulty breathing, even with they're on a ventilator, and they're getting nutrition through a peg, and their mobility is essentially not getting out of bed at all, or maybe transferring to sit in a chair, and the caregivers are just stretched to the limit, and the burden of care is becoming very difficult. And the patient may, what I try to do is talk about these issues as early as possible. And what I mean by that is often that means as early as the patient can tolerate it, right? Sometimes it's just not a conversation that the patient can have emotionally. And if I can defer it, I will. But over time, getting to know the patient and getting the patient to trust me, I will introduce that and try to get a feel for what they would like to do as the terminal events of this disease start unfolding. And some patients will make it clear, you know, when I do want to be on a trach, I want nutrition through PEG, but when I can't move anymore, my quality of life has been exhausted, and my family can't, you know, is really stretched. Then I can be. I want palliative care. You know, I want to have a peaceful ending. So this is this is again where the clinic is so well suited. The multidisciplinary clinic is so important, because these conversations, we're not talking about a 5-minute conversation that I can have with the patient on a 20-minute follow-up. Most of my follow-ups for the day are 20 minutes, right? I mean, this conversation could be 45 minutes, 3 visits in a row. So that's an excellent question, and everybody's going to be different, and it's really going to largely depend on the circumstances of the patient, their caregivers, and what their wishes are for end of life care. So I hope that was helpful.
Great, thank you so much. We have a few more questions and just about 5 minutes before our session ends. So if you'd like to go ahead and ask a question, please make sure that you enter it into the Q&A now. We have a question on glycoprolate, which apparently in an augmented device clinic, it was brought up that this was causing drying eyes out and making it hard to use the eye tracking devices. Has this ever come up before in other clinics?
Theresa, you want to answer that first?
Yeah, so glycopyrrolate does dry up the mouth, and that's why we sometimes suggest it for our patients who have excessive saliva. But in addition to that, it dries up other parts of the body. So the pupil or the sclera of the eye doesn't stay as moist. And so therefore the pupil does not focus as well. And so some people do have a harder time with eye tracking. And the other choices that we have of medications may be more beneficial for the vision, but not necessarily for the saliva. But Dr. Geraci, take it from there.
Yeah, that's exactly correct. It also, glycopyrrolate, its pharmacology can also impair pupillary movement, dilation, and constriction of the pupils, which are needed for visual acuity and seeing things sharply, as well as drying out the conjunctiva of the eye. So that's not common. It's probably would be most likely seen at the higher doses of the medication, such as 2 milligrams 3 times a day. And in that situation, I have found Botox injection into the parotid gland to be very useful. There are several circumstances where I may suggest Botox injection and then give that a try. And I have found that to be a very good treatment option. Probably 80% of the time, it's helpful enough that the patient can either stop taking the glycopyrrolate or greatly reduce the dose, and that would have no effects on dry eyes. So that can be a really good option too.
Great, and it looks like I have maybe 1 or 2 more questions here. So it sounds like the multidisciplinary method or clinic is really a great advantage for everyone. I'm curious to see, what about the time? How long would a whole day of appointments be, and how does the neurologist sort of tackle this with the whole team?
So, as I mentioned in my slides, depending on where you go and depending on your specific needs of the day, the appointment can take anywhere as short as an hour and a half to 2 hours, and sometimes the appointment be 4 or 5 hours. Some clinics have an overlap of patients, and you may have a period of time in between, like let's say OT and PT come in and stay with you for 15, 20, 25 minutes, and they leave, but there's no other available team member to come in to see you. So you may have to wait 10 or 15 minutes for that. So your appointment time may be in excess of 4 hours. The other situation, like I mentioned with my mother having to get up every day and taking my father 2 or 3 days a week to a different practitioner just to get some advice, then to pass it on to the doctor who said he didn't think it was the right appropriate treatment at the time, did take days, weeks, and then sometimes we didn't get the right answer. So the beauty of this is that everybody's there. We sometimes talk to people about things. Maybe somebody's getting a wheelchair and they have a communication device, and at that time we discuss the adapter or the shelf or whatever it is that's going to hold the communication device on to the wheelchair, and we mention it right then and there, so we know where to get the proper wheelchair and the proper adaptive equipment to go along with it. And so much less time used up when we have the person right there to talk about it.
And
Great. Oh,
I know
ahead.
that, I know we just got a few more seconds. I would just add, we if you look at the data nestled in what Dr. Scelsa presented, one of the major dissatisfactions that patients have with the multidisciplinary model is length of time. Sitting for 4 hours in a clinic can be arduous, and that can lead to decreased frequency of showing up in a clinic. We endeavor to, and we do see patients within a 90-minute to 2-hour window here at our clinic at Northwell. So I think it's important, but we are running around, Theresa and I are really running around and coordinating and doing all of that. So I think it's important to mention that as well.
Thank you so
Okay.
much. I think we are finished, right, with the time? It's 1:15.
Yeah, so I just want to make sure that folks know we want to thank our speakers and all of our attendees. And we've tried to answer all your questions. If we didn't get to your question, we will follow up with you. Make sure you can attend our wrap-up session with our chapter staff on Friday at 3:45, and we'll answer any outstanding questions at that time. Thank you so much.
Thank you, and we are here to help at any time. Please reach out to us. Thank you.